Do we need to unmute us?
We are unmuted.
Oh, okay. I think you will be able to see the door.
All right. Hello, everyone. Welcome to the Oxford University Global Surgery Group Conference 2020. I will hand it over to Professor Kokila Lakhu to start this conference.
Hello, everybody, and welcome to the Oxford University Global Surgery Conference 2020. We titled this conference Surgical Priorities in a Global Pandemic. I'm sorry we cannot meet you face to face because this is the week where we would have had our meeting. But be as it may be, we will now like you to enjoy what we have put across together today in the form of a mini conference. In Oxford, our global surgery group is made up of 4 departments, and we have leads for all 4 departments, starting with the Department of Anaesthesia with Hilary Edgcombe leading that group, the Reproductive Medicine group with Anita Makins, and the Orthopedic group with Chris Larvey, and Surgical group led by myself. I will now hand over to Tony, who's going to go through the rest of the conference with you. Thank you very much.
Thank you, Kokila. And may I add my welcome to all of you. There are many old friends and former students. Welcome. But a special welcome to those of you for whom dialing in was a real struggle and every day live with global health inequalities. We need your input and your insight. Welcome all those who are new to surgery, giving it a try. We hope you'll find much to interest and inspire you today. This afternoon, we'll be exploring the continuing need for obstetric, anaesthetic, and surgical interventions and thinking despite the COVID-19 pandemic. First of all, a word about questions. Please post any questions that you might have on the YouTube chat, which is just here on the right of the screen. Our team will gather them together and arrange them, and we shall discuss some of these questions with the speakers during the panel at the end of the conference. If you have any concerns about logistics or difficulties, please write them using the YouTube chat function. Well, on to our speakers this afternoon. Our first speaker is Hilary Edgcombe, a consultant anaesthetist here in Oxford, also an Oxford graduate, who holds a Master's in Global Health from King's College in London. She runs the well-known, well-established Anaesthesia in Developing Countries course in Uganda, and amongst other things, is a member of the leadership team of the University Global Surgery Group. Her talk is entitled Maintain Life, Anaesthetic and Intensive Care Priorities in a Global Pandemic. Over to you, Hilary.
Thank you very much indeed, Tony. And let me just get my slides up for you now. Great. So good afternoon, everyone. Thanks very much for signing up to this webinar. I am delighted to be contributing, and I've been given the opportunity to try and highlight some of the particular challenges to anaesthesia and critical care communities globally as a result of the pandemic. First of all, I thought I would take some time to set the scene for us. I'll start by looking back. Over the last 8 months, a lot has changed, and in order to situate our discussions this afternoon, I'll walk us through a very brief overview of our pandemic journey so far. So back in early January, if you remember, many of us may have only been quite dimly aware that an atypical pneumonia had emerged in Wuhan. Our colleagues in infectious diseases were concerned. They were worried this was going to turn out to be disease X, a previously hypothetical, unknown pathogen with the potential to cause a global epidemic. And that threat seemed much more real in late January, when within 3 to 4 weeks of the initial information coming out of China, the first cases were already documented in the US and in Europe. Within another 2 weeks, the first case had been documented in Africa and the disease had been given a name. And by early March, the world is wide awake to the threat of COVID-19, and the World Health Organization declared it to be a pandemic. The majority of countries acted pretty quickly, using a variety of social measures, in large part forms of lockdown, to control the spread of COVID-19, but nonetheless, it became rapidly established in community transmission around the world. And all this happened within 100 days of the first documented pneumonia of unknown cause in Wuhan. Over the last couple of months, progress has been made in identifying successful and unsuccessful drug treatments, and work to find a vaccine continues at an extraordinary pace. But it has become apparent to all of us that controlling transmission without stringent and economically damaging lockdown is very, very difficult. Cases and deaths continue to rise globally, and many regions which had seen a drop in cases are seeing a further rise or a second peak, as is currently the case here in Europe. So it's been quite a journey over the last 8 months, and we don't know quite how long this road is, and we don't know exactly what lies ahead of us. But it is fair to say that there has been a lot of progress. This slide just highlights a few of the areas where research and translation of that research has been happening at a phenomenal speed. There are still a number of vital questions which are unanswered to date. So, for example, how do we explain the variable mortality that we're seeing in different places? Country case fatality ratios seem to vary between 0.5 and 10%. There has to be a multifactorial answer to that, and some of the contributors are obvious, like existing health system strength, demographic data, and issues to do with data collection around COVID-19 itself. But it may not be quite that simple, and I'll come back to that in a moment. We've also got emerging stories of people who've been reinfected. Only a handful of cases, we think, so far, and given the number of cases around the world, it really is a very, very small proportion. But we don't quite know going forward how much of an issue that's going to become. And of course, we all pin much hope on a vaccine, but we don't yet have hard clinical data that we want on the efficacy of the many in development. It may be that more than one dose or combinations of more than one type of vaccine will be needed to sustain effective immunity. Even if a single vaccine is effective, the challenges of rapidly immunizing the global population is going to need an extraordinary effort of global collaboration across states and institutions with very different structures and philosophies. Along the same lines, ensuring basic food security globally in this context, with the ways that the pandemic's already affected national economies, trade and supply chains, is going to be a challenge for many areas and obviously has health implications. So I said I'd come back to the issue of death rates, which are higher or lower than might be expected in some areas of the world. And particularly at the start of this pandemic, some voices were heard speculating about what the impact of this particular infectious disease might be in sub-Saharan Africa, and what the effect would be in those countries which had limited or fragile health systems. Early modelling suggested death rates might be lower for a given case rate in some countries because of a younger population. But this might well be offset by the relative fragility or low resourcing of health systems in the same places. If we look just at COVID-19 related deaths, rather than overall excess deaths, which is obviously also important, per million population, we can see here the relatively worse mortality in Europe and the Americas in green and orange respectively, compared with Africa, which is the very slim blue line that you can barely see near the bottom. If we look at case incidence rates rather than mortality, we also see a low incidence of confirmed cases in Africa. This is data from Johns Hopkins. And there's been some interest as to why that might be the case. We know that many countries, if not most, on the continent were very quick to initiate testing at some level because many of them have handled high consequence infectious diseases before. Nonetheless, at least part of the explanation for the low incidence rates could well be limitations in testing and data collection, as we know that affects data from all around the world to some degree. But there might be some other factors coming into play. Antibody studies in Kenya, Malawi, and Mozambique demonstrate relatively high exposure rates to the virus, which are not consistent with the available data on symptomatic COVID-19 and COVID-19 mortality in the same areas. I'd really recommend to you this discussion recently published in Science. While the authors recognise that this may all simply be a reflection of difficulties collecting data, they do cautiously suggest that the virus might be spreading with an attenuated outcome in Africa. And they raise a variety of reasons why this might occur, including political strategies, demographics, environmental factors, and genetics, any or all of which could be a source of great learning for us globally as we try to cope with the pandemic. So these are questions for everyone. They're broad and they're important. I wanted to include them by way of context setting for this afternoon. But my remit is to speak about anaesthesia and intensive care. And so now I'm going to highlight 3 key areas of particular challenge for us worldwide. So firstly, the direct care of COVID-19 patients. It's clearly still needed. In some countries, recent focus has been far more on the social and the economic outworkings of the measures we've taken to limit viral spread, and those things are massively important. But in-hospital care remains a current challenge, and anaesthetists and intensivists worldwide are likely to continue to be primary medical providers for these really sick patients. Just to illustrate the reality that this is all still current on a global scale, here's a graph of cumulative deaths per 100,000 population for the 10 worst affected countries in the world. And really what I want you to notice from this slide is that although some of those curves are flattening out, many are not, particularly focused in Central and South America at present. So direct care of COVID patients, including some who have life-threatening disease, is still a reality. When it comes to that direct care, we are in a better place than we were. A lot of the work that's gone into trialling drugs for COVID patients is now coming out with results. And I'd strongly recommend to you this resource that the BMJ are providing, what they call a living systematic review, which means it's updated. They've produced this helpful infographic reflecting the strength and the quality of evidence for outcomes that you choose related to a number of different drugs which have been trialled. So here mortality has been selected, and the drug categories with good support for survival benefits are the glucocorticoids and remdesivir that you see in the green dots. And then all the others that you see in pink don't show any difference in mortality from standard care. There's a lot more information in that infographic and the way that they've laid it out about the quality of the evidence and the degree of difference that's shown. But it's a really useful overview of what's coming out of the literature worldwide. So we do have more options than we once did. Alongside the drug trials demonstrating the usefulness of glucocorticoids, we have some data around benefits from proning. We know some negatives. It seems unlikely that hydroxychloroquine is as useful as was once hoped, although there's some evidence for reduction in duration of symptoms. And plenty of work still going on to evaluate existing repurposed drugs and to develop new ones. Having said all that, the mainstay for management for our sick patients with COVID is still supportive. And depending what denominator you use, oxygen may be required by around 15% of patients who have symptomatic COVID-19, and mechanical ventilation by something like 3%. Well, neither of those management modalities are readily available to all populations around the world, as we know. I wonder if you remember this. Back in March, April and May, we saw huge numbers of headlines along these lines. Every company and innovator was making a low-cost ventilator, and there was considerable traffic and trade in ventilators, and the fear was that this would be the limiting factor for patient survival. What wasn't as well recognised in the public eye and perhaps the political eye, probably because it was a much harder problem to face, was that ventilators are not much good without accompanying infrastructure. In some UK hospitals, oxygen supply became a limiting factor before ventilators did. In the low resource setting, the media focus on ventilator donations didn't reflect the challenge of safely providing ventilation to patients at scale, especially in areas where it hasn't occurred before. Just to highlight some of the wider needs around ventilation. If you're going to put a patient on a ventilator and have them survive and get off it again, you're going to need someone with intubation and extubation expertise, and someone, maybe the same person or maybe not, who's an expert operator of that ventilator, who's been adequately trained, and they're going to need PPE. Most ventilators need pressurized driving gas in addition to the oxygen the patient requires. Most ventilators require good quality electricity. And importantly, they need to be able to handle the COVID lung. The simple bag squeezers that many have developed may have value as a temporizing device, but they won't help the patients with really severe lung disease. And of course, in the longer run, consumables and maintenance will also be required. And some countries and some centres may find that more difficult to access than others. So all of those infrastructural needs have to be addressed if giving a ventilator to a hospital is going to make a difference. What grabs far fewer headlines, but which would be of benefit to far more patients, would be adequate oxygen provision in hospital facilities around the world. And efforts are being made to raise awareness in the scientific community about the relative value of oxygen in fighting COVID-19, as well as all its other benefits, of course, to patients in hospitals. Up until the last few weeks, it hadn't really acquired much media attention. That is now starting to shift. But the focus remains for many hospitals on supplies of liquid oxygen and cylinders, and both of those can reach their limits and can do so quite suddenly and be difficult to address. We know that even pre-pandemic, there was a problem with oxygen supply in low resource environments. This is a typical study. It came out in 2010, reflecting the availability of oxygen in 8 low and middle income countries around the world. They looked at 132 facilities. And it demonstrates very clearly that if you are a patient in one of these facilities, pre-COVID, you cannot count on oxygen being provided to you if you need it. It's worth noting that the technology already exists to procure oxygen on site or locations with a functional power supply without having to depend on liquid oxygen plants and cylinder infrastructure. Oxygen concentrators, which you can see second from the left in the illustration, have existed for some decades. They do need a power supply, but they can produce 95% oxygen filtered from room air. There's a WHO standard for their function. And they've been used in low resource settings for decades, but have been slightly less well recognized in the high income context outside domiciliary use. Any hospital with a functioning oxygen concentrator and a reliable power supply is going to be in a much stronger position to keep supplying high flow oxygen to their patients indefinitely. If you would like to know more about that, I'll just refer you to this guidance which came out from WHO quite early on in the pandemic, which is still extant. It provides a great starting point to understand the options available and tools for those of you who might be involved in predicting or planning for increased oxygen supply in the centres you work in. So I think it's fair to say that as anaesthetists and critical care community involved with the most severely affected patients in hospitals, direct care is still a challenge for us. We particularly need better oxygen provision at a global scale, and we need more progress on effective drugs. The glucocorticoids are great news, but we look forward to more tools to be available to us. Then more briefly, the second area of challenge for us as a community is around the ability to provide surge capacity within hospital facilities. And as perhaps we all know from our own experience, difficult choices have been made everywhere. Surge capacity has to encompass physical space, equipment resources, pharmaceutics, and human resources. It's worth noting that the knock-on effects of the pandemic on international trade and manufacturing are pretty significant for drug availability. And the pace of the pandemic in India at the moment, which is the biggest provider of generic medicines in the world, is a major concern from that point of view. In many centres, the solution has been to stop or to slow down the pace of elective surgery to enable operating theatre resources in all those categories to be used for COVID-19 patients. That resource is clearly more limited in centres which didn't do a lot of elective surgery to begin with. What I've put up here is just a study that wanted to quantify the emergency to elective surgery ratio in centres around the world. At the point where they did the study, it was used as an indicator for access to surgical care. But it gives us an idea of how much centres in different locations are likely to be able to drop elective surgery if they choose to, in order to increase their capacity for COVID patients. A centre with a higher EE ratio does proportionately more emergent surgery and might be presumed therefore to have less surge capacity. And it will not be a surprise to anyone that this is more common in the low and middle income setting. Of course, whether elective surgery should be stopped in order to facilitate ventilating COVID-19 patients is an ethical issue which is not at all straightforward to resolve. And different regions will make different decisions at different times, depending on their situations. Those decisions will have longer term implications for populations' health, especially for surgically treatable disease, which have yet to work their way out. Then the third, and I would suggest the longest term challenge for anaesthesia and critical care communities, is the impact on the workforce. There will be some who suffer ill health or even die of COVID-19 in the same way as the wider community or related to their work, especially in places where PPE is difficult to access. There'll be many whose training has been interrupted or abandoned, or who have difficulties accessing training going forwards. And there may also be recruitment issues with the workforce. Countries with strong training infrastructures may be able to develop strategies to help with that. But in countries where the workforce was already stretched, the consequences of the pandemic for safe surgical provision in the long run are potentially quite bleak. So those are three challenges, I think, that the anaesthesia and critical care communities face. And I suppose it just remains now to ask, where next for us? Within anaesthesia and critical care, I think the two key areas to focus on now and over the next months to years, in a way, haven't changed from pre-pandemic. They've just become more painfully evident. We must develop facilities capacity for oxygen provision. It clearly has wider health benefits than for COVID-19 patients alone. And we must build the workforce, thinking about strategies now for ensuring an adequate number of well-trained providers to help with safe surgical care in the decades to come. And then for all of us, whether we are anaesthetists or surgeons or obstetricians or any other interested party, let's recognise we're still in the middle of this journey. In the last 6 months, we've seen amazing collaboration and adaptation, but it's not over yet. And I think the story of the next 6 to 12 months will be in the fight for health equity, and particularly in the area of global surgery, which will be hit hard by the effects of the pandemic. Let's keep collaborating and communicating to help adequate access to healthcare for all our populations, whether that's vaccination, access to caesarean sections, or critical care that a patient needs to survive this or any other infectious diseases. Thanks very much for your time. Back to Tony.
Thank you so much, Hilary. If anyone listening or watching has got any questions for Hilary or any of the other speakers later, do post them on the YouTube chat thing on the right-hand side of your screen, and we'll collect those questions and put them together for our discussion at the end of the conference. Now, we're moving to our first of our 3 interviews. We've got 3 interviews this afternoon, all being undertaken by Global Scalpels. Global Scalpels is a group founded earlier this year by Taylor Otterson and Rihanna Patel. And they are junior doctors who want to highlight the people involved in the most creative and innovative projects in global surgery, which include technical advances, advocacy, and research. If you want to know more about Global Scalpels, please visit their website. And our first interview this afternoon is with Dr. Pierre Wooley, an orthopedic trauma surgeon from Haiti. So over to Global Scalpels.
We'd like to welcome our guest today. He is a personal friend, Dr. Pierre Wooley. Dr. Wooley is an orthopedic trauma surgeon based in Port-au-Prince, Haiti. After completing his residency in Haiti, he completed a trauma, pelvic, and acetabular surgery fellowship in the United States. He now serves as an associate professor at the University of Notre Dame School of Medicine in Haiti and the orthopedic residency academic director at HUP La Paix State University Hospital. He also serves as the major liaison for the Harvard Haitian Annual Assembly for Orthopedic Trauma, or HAOT. His passion lies in research for improving education and global surgery in his home country of Haiti and other low-income countries. So with that, we'd like to welcome Dr. Pierre Wooley.
Thanks for having me, guys.
It's our pleasure. We're excited to have you and talk a little bit about both COVID as well as the Haitian earthquake back in 2010. So for our listeners who aren't very familiar with that earthquake, could you tell us a little bit more about the earthquake and what was the aftermath in Haiti like?
Yeah, so the earthquake happened in 2010, in January 12. For those who don't remember that around the world, I think that was probably because they weren't born yet or they were very young, as this was in major news all around the world.
Yes.
So it was a 7.2 magnitude earthquake that happened a little bit around the capital of Port-au-Prince, which is the capital of Haiti. And it was it was quoted as the largest urban disaster in modern history. We had about 250,000 people died and around 300,000 people injured. And we had like about $14 billion, I think, of loss, and over 5 million people displaced from their homes because of that disaster. So it was a pretty big disaster, and that really made the news around the world.
You mentioned a lot about the human cost and obviously the economic cost, but how did this earthquake affect the medical infrastructure and the medical system?
So everything went down around Port-au-Prince area, and so Haiti is already a low-income country. We are the poorest country in the Western Hemisphere. We were before the earthquake one of the poorest countries on earth, and so always hit by social, economical, political unrest all the time. And so that natural disaster just tear down everything, including the infrastructures for healthcare. So we were really faced with even dire problems because of what we didn't have before, and just that the structures, the hospitals, the buildings kind of collapsed, most of them. So it was a really big deal at that time, and it was a really traumatic incident that none of us will ever forget, for sure.
Can you tell us a little bit more about the medical system, like the personnel and the workflow? What happened during that time? Obviously, it's kind of like COVID, where we are just suddenly, the healthcare system was bombarded with, like, overcome with so many people all at one time. So can you tell us a little bit about what it was like being in that situation?
There's a lot of similarities between COVID pandemic and the earthquake. I think the difference between COVID pandemic and the earthquake was mostly, earthquake was traumatic. It was a one-time one moment thing, and it just created, it just generated a lot of problems at one time, whereas COVID is pretty much still going on and still creating the problems. But in terms of saturation of the hospital, it was pretty much the same thing. A lot of people got injured in one time, and the healthcare infrastructure wasn't ready to receive those people. And what happened at that moment was that people just went to the hospitals, multiple millions of people going, in hospitals that were already collapsed themselves. And so the workers, the health professionals, everybody was, trying to tend to their families, trying to understand what was going on. So it was really a chaotic time. And the saturation of the hospital, the people going into the hospitals, pretty much like COVID, they didn't have enough beds. Those hospitals that were still standing, and it was just a big chaotic magna of problems. And I guess the only difference is, over time, hospitals got saturated from the capital going up to the provinces, whereas COVID, everybody is still getting saturated because nobody knows what to do. So it's just a bad. It was a really bad time for the country, and it really showed us, how a disaster of a great scale can just collapse everything in just a few seconds.
And I know these are obviously disasters or natural disasters in two very different forms. What lessons did you learn from the earthquake that you found to be relevant to dealing with COVID today?
I think that what is relevant is what you learn from those traumatic experiences. The earthquake was, like I mentioned, the largest urban disaster in modern history in terms of trauma. And what we learned from that was, first of all, we weren't prepared. Can somebody be prepared for such an event? I don't know. I have the answer for that. And the other thing is, what can you do to prevent it? I don't think there's also an answer to that, because it is an earthquake. You can't, scale, what you can respond. So I think what we mostly learned out of the earthquake was how to respond to such a disaster in a way that's going to save the maximum people and the maximum lives. And COVID, I think, is the same thing, because it just hit the world in one time, and not knowing. I guess the difference is not knowing what it was initially. So people were like, we should do this, we should do that, and we don't know what to do. Whereas the earthquake, it was trauma. We just didn't have the resources to do what we needed to do, or the infrastructure to help us in that sense. But it's also the same mass casualty, mass people going to the hospital, and just, you're dealing with a disaster that, is unprecedented. Both of them in their own form, and you don't really know what to do, and you're kind of going along with it as times progress. And you do make a lot of mistakes initially, for sure. Both.
Sure. I mean, we are going to make mistakes when you haven't seen anything, and that's why we do lots of training for disasters and different things in our medical training, right? Is to be able to prepare for some of these things. But as you said, no one is prepared for the largest earthquake or for a global pandemic that was completely unexpected. So,
I think what you just said is, I think that the last part of what I was going to emphasize on is that you learn from what happened. And actually, the disaster management protocols in the US, for example, a lot of them were lessons learned from the ground in Haiti. So what they changed their protocols, their drills, how to manage mass casualty disasters, and really learn from those experiences. So there is also some positive out of those major pandemics.
Yeah, definitely good lessons learned. Shifting a little bit more towards COVID, how has COVID really been affecting surgery in Haiti for you, and what adaptations have you guys had to change because of that setting?
Well, we have to be honest and say that we've been fortunate enough to have respected a lot of the principles early on. The government closed the borders very early on in this pandemic, in early March, and when the US was actually trying to understand what was going to happen. And so by wearing masks and social physical distance, I call it physical distance, not social distance. But it's, we've been lucky enough to have less than 250 deaths so far over 6 months. And we are not as affected as some of the other places. We did have the month of June where we had a bunch of cases, but our hospitals were never saturated to a point of no return, especially in a country like mine where it's a low-income country. You don't have the resources, you don't have the manpower or the ventilators or anything like that. So I think that we were I guess blessed enough or fortunate enough to not go to that point. But we did respect a lot of the principles learned from other countries, mostly the ones in Europe. We did take their advice early on, and I think that's one of the things that kind of saved a lot of what could have happened so far.
And I think what you're saying makes complete sense, that prevention, especially when you know that your healthcare infrastructure or any healthcare infrastructure would struggle to deal with the volume of cases that some countries are seeing. Thank you so much for speaking to us about your experience with both the earthquake and also has been relevant to this current pandemic. It's been really useful to hear about this experience.
Thank you very much. I really appreciate being here, and thank you for the invitation to share our perspective on this thing that it's affecting all of us. So for sure, thank you.
Thank you so much. I think it's really important. And for those of you listening at the conference, if you'd like to hear the rest of this episode, you can go to globalscalpels.com and listen there, or you can watch on your favorite podcast platform, whether it's Apple Podcasts or Spotify. So we thank you for joining us.
Well, welcome back to the conference. Rihanna, who was conducting the interview, is a member of the Oxford University Global Surgery Group, where we welcome anyone with an interest in global surgery, whatever stage of their career journey they are. We have students, we have a lot of active clinicians, and we have even some retired old buffers. Our next speaker is another leading member of the home team. Anita Makins is a consultant obstetrician and gynecologist in Oxford, and she spends half her time doing that, and the other half of the week she spends with FIGO, the International Federation of Gynecology and Obstetrics. She has a master's in public health and spent several years working in sub-Saharan Africa in emergency obstetric care, gynecology and fistula surgery. And she's a member of the leadership of the Global Surgery Group. And her talk is entitled The Impact of COVID-19 on Sexual and Reproductive Health at a Global Level.
Thank you very much, Tony, for that lovely introduction. I'll just share my screen so you can see my slides. Okay. Okay, so as Tony said, so I'm going to be talking to you about COVID-19 and its impact on the sexual and reproductive health, sort of across the world. So the COVID-19 pandemic took the world by surprise, as Hilary has given us a lot of information about how it started, where it spread. This map is just showing the most recent update in terms of infection. So the WHO publishes a situation report on a weekly basis now, looking at how infection rates are across the world. And you can see here the darker brown are the countries or the areas with the highest cases reported in the last, this is the most recent week that they published, so from the 7th of September to the 13th. And you can see there that the Americas are still the big hotspot, actually accounting for more than 50% of cases reported, cumulative cases reported so far. And we've talked a little bit about how the movement to Southeast Asia now, with very rapidly increasing rates in India and so on. But in total, there's been 28.5 million COVID-19 cases reported, and 900,000 deaths, so nearly 1 million deaths worldwide, so hugely worrying. So when in February, when all of the data was being banded around, so whether it was on the TV, whether it was on the internet, all these sources of information that we had, it was really difficult to understand what were the correct reported rates and how should we be measuring COVID-19 infection rates. I'm Brazilian originally, so I have a particular interest in what was going on in Brazil, and it was bizarre at the start because we had, for example, reports coming from Manaus of very drastic situations, but when you looked at figures that were reported in newspapers and stuff, it didn't really quite tally. So just to give you an example here, the mayor of Manaus, which is the capital city in the Amazon in Brazil, quoted here, "We aren't in a state of emergency, we're well beyond that. We're in a state of utter disaster, like a country that's at war and has lost. We don't have hurricanes here, we don't have tsunamis. Here, the tsunami was having disregarded social isolation." And he actually called for international help because he felt that his government was not giving him the due support that he needed. And you can see there, the photo on the right is a photo of mass graves that they were digging in order to bury these people that were dying of COVID-19 because they couldn't cope. And the photo on the left is one of the local indigenous population of the Amazon, and they were particularly susceptible to the infection, and large numbers of indigenous Indian people, unfortunately, have died as a result of the pandemic because they live remotely and also couldn't access help, never mind the sort of information about how to protect themselves from it. But then if we look, so on to the next slide, if we look here at sort of the distribution of cases across Brazil, so the map on the left is looking at the number of cases reported in the country, and then the one on the right is looking at the number of deaths. And you can see there that the darker colours are where most infections, and at the Amazon is the state on the top left. And you can see it is darker coloured, but so is the state of São Paulo, so is the state of Rio, and it's actually quite spread throughout Brazil, including the northeast, for example. But then, so clearly a problem in the Amazon, but probably not much more of a problem than when you compared it to the rest of the country. But then if you look at this map, which is looking at the number of cases per million inhabitants on the left and the number of deaths per million inhabitants, you can see here why the mayor was absolutely right in saying that he had a disaster on his hands, because the Amazon or the Manaus area was clearly with a huge number of infected cases, but also deaths per population. So it's a very sparsely populated part of Brazil, and was very badly affected. And then, so as time went on, when all these numbers were being banded around and all these different websites that you could look at with the different, estimations of infection rates and so on, gradually there then became other ways of measuring it. For example, so this again is from the Brazilian Ministry of Health website. So looking at hospitalizations by acute respiratory syndrome, comparing the year of 2019 to the year of 2020, and you can see there, phenomenal increase in admissions in hospital with severe respiratory symptoms in 2020 compared to 19, so something like 8 or 9-fold higher, as the pandemic started spreading throughout the country. And to say that sort of what was eventually used was actually comparing, for example, deaths in 2020 compared to deaths over the previous 5 years over the same months. That's also another way of sort of eliminating this concern or this bias that you have for lack of testing, which I think explains why the numbers are confusing when you look across the world, and perhaps accounts to some extent what Hilary was saying about what's being reported about deaths in Africa. I toyed with whether to keep this article in or not. I still think it's worthwhile. So it was an article produced by the Imperial College in May. So they were looking really at equity in response to the COVID-19 pandemic in low and lower middle income countries. And what they were trying to point out was that some of the strategies that we had ongoing at the time in terms of preventing infection were going to hit different areas of the world differently, and different populations within those areas of the world as well. So these graphs, if you look at the top left, it's looking at the proportion of households with soap and water in low middle income countries, so dividing the population into the quintiles of wealth. So on the left, you've got the darker green squares are looking at the wealthiest proportions of the population, and then on the right, you've got the poorest quintiles, and you can see that access to water, soap and water, sort of less than 25% in the poorest portion of the population. So, you know, the message that you have to wash your hands for 20 seconds using soap and so on, it's fine to give it out, but if people don't have access to water, then they can't wash their hands. The graph below is looking at people's occupation and whether the likelihood of them being able to work from home. And here, you know, you're looking at the wealthiest quintile, you can see about 25% of the population might be able to revert to working from home. But as soon as you move into the middle, poorer or poorest quintiles of the population, they cannot work from home. So if your income comes from selling goods in the market or subsistence farming or whatever, working from home is not really an option. And then the graphs on the right are looking at distance to the nearest hospital. So again, the dark green is the wealthiest portion of the population. You can see that their access to, or distance they have to travel to get to hospital is much less than the red on the top, which is the poorest quintile. So they're obviously traveling much further to reach health. So a strategy of washing your hands, staying at home, and only going to hospital if you're really sick doesn't work if you're in the poorest quintile of the population of your country, in low middle income countries anyway, for sure. So here what they did is they looked at those three risk factors together, and the compound impact meant that there would be predicted a 32% increase in the probability of death in the poorest quintile compared to the wealthiest quintile within that country. So looking at the population within these low middle income countries. So when we move on to talking about what's happening, what the likely impact would be in obstetrics and gynecology. So you can look at two results. So you could have the direct results, the consequences of being infected with COVID-19, and luckily, or there's been a positive finding is that actually pregnant women who get COVID-19 do not seem to be any worse off than their non-pregnant counterparts. So yes, they can get infected, yes, they can get very unwell and go to ITU, but they're not more at risk of that than the non-pregnant women. There's not a lot of evidence about what happens if you get infected with COVID-19 in the first trimester, and so that's still something that we need to keep an eye on. But for sure, in terms of the maternal consequences of infection, it doesn't seem to be any worse. However, what's much more concerning is that are what's likely to have been the indirect effects of different measures that were taken, so lockdowns and so on in the different countries. So our fear is that it's likely to have increased morbidity and mortality related to what we call the 3 delays. So many of you may have heard, for those working in obstetrics, we talk about the 3 delays model. It's something proposed by Tadeusz and Main in the 80s, looking at the fact that why does it take so long for a woman to reach healthcare when she's pregnant? So the first delay is making the decision to go to hospital. The second delay is actually reaching the hospital once you've decided you're going to go, actually getting transport. And the third delay is the delay to actually receiving the care once you get to hospital. And you can imagine that with COVID-19, all of those 3 delays are enhanced. So people are less likely to want to go to hospital because they don't want to catch this disease that they're reading about. Secondly, once they do decide that they need to go to hospital, that actually transport systems were such that they weren't working in the same way or aren't still working in the same way. And so there'll be the delay in reaching care, and then the delays in hospital itself. So fewer human resources, perhaps because doctors, nurses, perhaps unwell from having had COVID-19 themselves, or the fear of catching COVID-19, or even delays related to access of different kinds of medicines that you might need, because supplies aren't reaching, and so on. So potential for huge harm in that respect. And then if we think about the unplanned pregnancies that could result from women not accessing contraception in the way they usually do, that increases morbidity and mortality. And then related to the flip side of that is unsafe abortion. So if there are unplanned pregnancies, then the number of unsafe abortions goes up as well. So And to the next slide, the Guttmacher Institute, or authors from the Guttmacher Institute, tried to put some numbers down into what that might look like on a global scale. So they estimated the impact of a 10% decline in the use of short and long-acting reversible contraceptive methods. And what they showed was that they thought there'd be about 48.5 million additional women with an unmet need for modern contraceptive. So this is a lady who is married and who wants contraception but cannot access it. An additional 15.5 million unintended pregnancies. And if there was a 10% decline in coverage of essential pregnancy-related and newborn care, that you'd have nearly 2 million additional women experiencing obstetric complications without the care that they need, an additional 28,000 deaths, and more than 2.5 million additional newborns having complications without care, and 168,000 additional newborn deaths. And then again, with regards to abortion, so the increase, there would likely be a 10% shift from safe to unsafe abortions, causing over 3 million additional unsafe abortions and 1,000 maternal deaths. So it looks really bleak when you look at these numbers as a whole, and this is only with a 10% decline in the use of contraception. And the thought is that is currently a lot higher than what's predicted there. When we look at lessons learned from the Ebola epidemic in Guinea, so this was a paper published looking at what happened to access to these different forms of healthcare during the pandemic. You can see on the left there, the graphs looking at antenatal clinic visits. One antenatal clinic visits, or the dotted line, is more than 3, which is the WHO gold standard for antenatal care. And you can see during the Ebola epidemic, there was a considerable drop in antenatal clinic attendance. So people were scared to go to hospital and not thinking that it's something that they absolutely have to do. And then on the right, looking at family planning, very similar scenario. So the black line is looking at total family planning methods, and then you've got the red, the dotted, the grey, and the dotted for implants, pills, the IUD, and depot injection, and all of them dropping over the Ebola epidemic and having some recovery after the epidemic, but still not full recovery. So, although we don't know what the impact of the pandemic has been, for example, or is likely still to be in Africa or not, what we do know is that the effects of having had lockdown are absolutely very severe for maternal health and sexual reproductive health. And so we need to be thinking about, so what can we do to minimize that we need to be doing now? And with FIGO, we've worked a lot on trying to disseminate information about what we can currently do to reduce this impact and improve things on the ground. And we came up with six standards of practice, if you like, and I'll go through those one at a time. So firstly, to increase postpartum family planning. So rather than a lady having to come back to have contraception or family planning discussed at 6 weeks, which was the old model, to be providing postpartum family planning when she comes for delivery. So many women, although we have seen that institutional birth rates have decreased during the pandemic, so I work very much in Bangladesh. Bangladesh saw almost a drop of 2/3 in terms of the number of women coming in for institutional birth. But in many parts of the world, particularly South America, women will continue coming to hospital to give birth, whatever the situation. And so in those countries, it's really important that they then contact with the woman for delivery is used for much more than just delivering her baby, and family planning should be right up there. So we need to be talking about family planning antenatally, so that when a woman comes in, she knows what she wants, and focusing very much on long-acting reversible contraceptive methods. So I'm talking about the intrauterine device, coil, the copper coil, the intrauterine system, so that's the hormonal one for where it is accessible, which again is an issue in low middle income countries. And for those countries that have access to implants, that's also an option to be given immediately postpartum. And these are methods that are highly effective, and it means that a lady does not have to keep coming back for resupply. So there isn't this issue about not wanting to come and use health services. Secondly, in using the self-administration methods more. So if a lady comes to get her contraceptive method, rather than giving her 3 months of the pill, give her 6 months of the pill, making sure that emergency contraception is accessible. Rather than using intramuscular depot injections for ladies on depot, you can switch to the subcutaneous route, which means that they can actually self-administer at home. And this is quite common practice in many low middle income countries. Previously, it was thought that you'd use it for ladies who live far away. But I mean, in this situation, if people are staying at home, the same applies really. Plentiful supply of barrier methods, making sure that they understand how lactational amenorrhea, the LAM method, works, so when they can be sure that they're then not going to get pregnant when they're properly fully breastfeeding, and also vaginal contraceptive rings. They're also a good method to use during pandemic period. Thirdly, to remove barriers to access, so to try and simplify our processes, try to decentralize services, allow people to make decisions locally about how best to reorganize themselves in order to provide services. Task shifting and task sharing, again, really important. So midwives and nurses are perfectly able to counsel on contraception and actually give and prescribe contraception, or, for example, insert the postpartum IUD or implants. And so we should be encouraging that, so that not everybody has to see a doctor and therefore limit people's access to these methods. And for example, thinking about how pharmacists, if we can be more flexible about pharmacists prescribing contraceptive methods as well. So to try to remove these sort of bureaucratic or slightly old-fashioned rules which we've previously had about prescriptions. Fourthly, the use of telemedicine. So again, this is something that many sub-Saharan African countries have had sort of pilot projects, with regards to using mobile phones, sending text messages and so on. We really need to put this into practice and make it the norm, having call centres, using social media, even home delivery of methods. You can have outreach clinics and so on, or just home delivery of contraceptive methods that women are already on. With regards to supply chain issues, as this was a big concern at the start of the pandemic. UNFPA supplies contraceptive methods to about 46 low and middle income countries, and in February, March, they were talking about how they've had issues with shipment of components used in manufacturing contraceptives from China right at the start of the pandemic, and then after that with the lockdown in India, in the factories that were actually producing the methods, and how transborder transport was also severely disrupted. And so they started producing as quarterly reports about which countries were actually going to have issues with the supply of different methods. And actually the international community very much came together in terms of trying to mitigate and redistribute supplies of different methods. And what actually happened was that not as many countries had stockouts because of reorganization, but also because people started accessing it less. And so this didn't materialize in as many countries as was predicted. But what it did do is it really exposed the whole very precarious situation of family planning financing. So this is a pie chart looking at the proportion of contraceptive funding by World Bank low-income countries. And you can see there that domestic financing of contraceptive methods accounts for only 2% of the total financing. There's 23% is the private sector, but all of the rest, so 75%, is organized by people outside of the country. You've got USAID there, 28%, UNFPA, 28%, government managed donor funds, NGOs, etc. So very precarious. How can a country be depending on external supply or financing of something so important like contraceptive methods? So really, we need to be pushing for countries to be spending what they need to spend on contraception in particular, but on sexual and reproductive healthcare type products. Lastly, in terms of personal protective equipment, so PPE, I think we said that it was important that there should be transparent sharing of information about the mechanisms of transmission, so that and the local epidemiology, so that actually locally people can decide what it is they needed to do in terms of provision of PPE, so that healthcare providers could make proper informed decisions about how best to continue providing services in a safe manner, and also able to predict stockouts locally and look for local solutions to these issues. You can see there the picture on the right as an example of masks being sold in the market in Mozambique, and on the left there in Brazil, ladies putting PPE material together just at home. So on the positive side, in terms of how low middle income countries have or are or will deal with the situation, to say that
Anita,
yeah.
just in the interest of time, can you wrap up really quickly?
Yeah, this is my last slide, yeah. So healthcare workers are used to dealing with infectious outbreaks and emergencies. And it was interesting to see, for example, the WHO Director General asking the head of the West African region to talk about how he'd actually eradicated Ebola in the country, and just talking about basic, going from house to house, knocking on people's doors, asking who their contacts are, tracing those, and actually a real south to north learning about how to do contact tracing in infectious disease outbreaks. Also to say that low middle income countries are already task shifting, sharing, and so that they can capitalize on that they have community health workers, that's the norm, and so that can be used again for testing and tracing. Like I said, self-administration methods are more common. Innovation is very common as well. In Bangladesh, the TB gene expert was converted as COVID-19 testing hub, so that was a way of ensuring
Thank you very much, Anita. That was fantastic. There'll be just a very, very short break, but please stay tuned. And could you come back at 5 minutes past 3 in the United Kingdom, 5 minutes past 10 in Kuala Lumpur, 5 minutes past 5 in Nairobi in Palestine, 5 minutes past 10 if you're listening in Boston, and I'm afraid 5 minutes past 3 tomorrow morning if you're listening in Auckland. But welcome back. We'll welcome you back in 5 minutes. I'll go off now. Stop video. Well, welcome back. If you've got any questions, please use the messaging system on YouTube to ask them to us, and tell us of any difficulties you might be having. We know that some people will find it difficult to tune in, so if there are difficulties, do let us know. And we will be sending out certificates of attendance at the end of the conference. There'll be a link to the survey at the end of the conference, and it will also be sent out on email. So if you want a certificate with the Oxford University stamp on it, do let us know and we'll send you one. So our next speaker is Dr. Shobana Nagraj, Shobi, who's also a member of our team here in Oxford. She's a MRC Clinical Research Training Fellow in the Nuffield Department of Women's Reproductive Health. And she works in the fields of design and evaluation of complex interventions in implementation science, especially in low resource settings. And her talk is entitled Discovering the Important Research Questions for Surgery During the Pandemic and Beyond. Over to you, Shobi.
Hello, everybody. Thank you so much for inviting me to speak here today. My name is Dr. Shobana Nagraj, and I'm an MRC Clinical Research Training Fellow based at the University of Oxford. I'm speaking today about discovering the important research questions for global surgery, and I wanted this to be a very practical talk to translate some of the ideas you might be having over the last few months into research questions and think about study designs around these research questions. I know that some of you will already be very involved in research, and this is really a guide to really hone in on those important research questions. So I hope it's useful for you. To give you a bit of background about myself, I have a clinical background in paediatric surgery and in primary care, and I currently do research in the fields of implementation science and the design of complex interventions. So over the last few months, I've actually branched out a little bit from those areas and have been reading a bit around history, which I found really fascinating during this time. And it was during this reading that I came across this gentleman, who some of you might recognise is Sir Isaac Newton. In the 1660s, Isaac Newton was a student at the University of Cambridge, and he was in his 20s at the time. And in 1665, there was an outbreak of the bubonic plague in England, and students got sent home from their university to do what we're doing now, which is socially distance themselves from each other. And actually, during that time, it was actually known as his Year of Wonders, his Annus Mirabilis, which is actually most of his important discoveries were actually made during that time, because he had some time away from the structure of academia and time to observe natural phenomena. And it was during this time that he played with prisms in his room and saw the sunlight move through the prism to form rainbows, and had his ideas about optics. And also the very famous apple tree was in his garden, which inspired his subsequent work on gravity. So I'm really hopeful that during this time of lockdown and social distancing, that we as a global surgery community can also come up with some of our important discoveries and really do some excellent research during this time as well. So there have been quite a number of high-level meetings around the important research questions to ask during the COVID pandemic. And these are some of the areas that have been highlighted as areas that would have a lot of importance in terms of global health and population health. And they include the natural history of the virus, including cohort studies, which we'll come to a bit later, how the virus is transmitted through animals and the environment, sanitation around the transmission of the virus, and then using technologies such as geospatial location and mobile health applications to track and trace the spread within communities. The other focus of research has been around diagnostics and the invention of new rapid testing, and also looking at clinical management in terms of protocols, infection prevention, and the mental health of healthcare workers. A focus has also been on therapeutics and different drugs that might be used in the treatment of COVID, and steroids, for example, have played an important role in this, the development of vaccines, and all around this, the ethics around conducting studies in a different way, using new methodologies in some cases, and also collaborating with industry. There's also been a focus on social sciences and understanding the behaviour and context in which these interventions might be implemented, and this has been a really important focus of research as well. And the global surgery community has actually embraced some of these areas, and there have been some really great studies over the last few months. For example, from the COVID surge team who are based, run out of Birmingham, there's been an international cohort study looking at the mortality and complications in patients who had surgery and had COVID at the time, which showed a lot worse outcomes for those who had COVID.
That and there are other international cohort studies currently running in global surgery as well. There have been local audits of paediatric surgical operations that have been cancelled during this time, and the implications of cancellation of elective surgery on the backlog that is going to now be in place. And then there have been some inventions such as this is the OXVent system, which is a low-cost ventilator which could be used and scaled up quite quickly because of its low cost. And then there's been using existing technologies to actually deliver surgical care in a different way. So use of telemedicine and telehealth to do pre-operative assessments on patients, and also provide post-operative follow-up of patients as well. So there have been some really great studies. I also like to think about research, not only about these high level priorities, but also what we can learn from observation on the ground as well. The study that really got me excited about research when I was a bit younger was this study in the Lancet of home-based neonatal care in the management of sepsis in rural India. And it was conducted by a couple of paediatricians called Rani and Abhay Bang, and they had gone to Johns Hopkins University to study their masters in public health, and they returned to work in a very deprived area of rural India. And during this time, they really got to know that actually a lot of the babies were dying in the postnatal period. And so they trained a village woman to be able to recognise the signs of neonatal sepsis and to administer intramuscular antibiotics at the time. And this package of care was called home-based neonatal care. And they designed a very good field trial around this and showed an almost 50% reduction in neonatal mortality and morbidity in what was a very rural, mostly illiterate and a malnourished population. And this was at the cost of just $5 per neonate. So this type of research really excited me. And I think what I really loved about it was that it addressed a clinically important need. It was a very well-designed study. It was prospective and it was an intervention study, and it was run in a real-world context. And it was published in a really good journal, which meant that it was disseminated and shared with a really wide community and was picked up by the WHO and actually is now being implemented in countries all over the world. So this is an example for me of research that can have a real impact on the lives of so many. And it's been really relevant during this time because we're not allowed to leave our home. So home-based care has been a really important type of care during this time of the pandemic. So when we're thinking about getting started in research and asking the right research questions, I think it's really nice to have two hats on. One is our clinician hat, which is often centered around the needs of our patients and what we've seen. So sometimes patients come to us with queries and we don't know the answer to them, and that can trigger off a research idea. And also having a researcher hat on is really important. So actually thinking about how you're going to design and conduct a study around this area, and would it be publishable in a good journal as well? And I think that last point is really important to consider, because actually we want to be able to share knowledge with other people and share good practice, and even if things haven't worked, also share that as well. So the first step is really thinking about what area interests you and what you want to actually look at. And once you have an idea of the area that you want to study, there are little pockets in that area which have uncertainties. And sometimes we don't know what the best treatment or best course of action is, whether we should do an operation, whether we should hold off surgery, whether we should give a particular drug or not. And these areas of uncertainty are at the heart of any great research, and it's called clinical equipoise, when we're not sure which would be better. And that's why we do research, is to find out, discover which path would be better for us to take. So once you've got these areas of slight uncertainty, it's really important to read and read and read around these areas. And it's through reading that you can really get an idea of what's already been done and worked, what hasn't worked. And then those grey areas become a lot clearer from the reading. And once you've got those grey areas, then you can actually think and hone in on those areas by reviewing the literature in those grey areas. And it's important at this stage not just to do a Google search, but actually to systematically look at the literature. And this can often be done by using databases such as PubMed, which is free to access. And there are several others depending on what field that you work in. And there's some very good online resources through the Bodleian Library and the Cochrane database and website, which give online tutorials and guides on how to conduct a systematic review or meta-analysis or a very robust literature review. So once the literature's been reviewed, you've got a really good idea, you've now got the areas of uncertainty, you've reviewed the literature around it, you can now come to the research question. And this, because this is really the focus of this talk, which is if you get the right research question, everything else follows from that, the study design, everything else. So I feel that this is the most important thing. So there are frameworks that we can use to get to a research question and to think about how to approach a research question. And one of those is the PICO framework. So to think about the population that we're interested in, what intervention or variable of interest that we're interested in, what we can compare that to, if anything at all, and what outcomes we're interested in. Are these going to be subjective outcomes, such as patient experience of a particular service, or will there be objective measurements such as mortality rates or post-operative complication rates? And what time frame we're interested in, whether it's a very acute time frame or we're interested in a much more long-term time frame. So over the last few months, I had some ideas that had come up in my head, some questions that I wasn't sure about. I'd noticed that a lot of people were losing their sense of smell during this time of the COVID virus. And in general practice, there was a bit of uncertainty on how you best deal with this loss of smell, because it can affect people's lives quite significantly and also impact on their taste. So I had a little Google about what you can do for improving sense of smell, and I found out that there is something called smell training. So you can actually do a type of training to regain sense of smell using essential oils. And then, for example, if you have a lemon essential oil, you can smell it for 20 seconds whilst picturing a lemon in your head. And apparently the brain can then start to make associations. So I had this question, which was, does smell training improve sense of smell after COVID-19 in people that had anosmia as their symptom? So at first glance, that might look like quite a nice question. And I think, I was quite happy with that question at first. But then looking at it in this PICO framework, population intervention, comparator outcome and time frame, then I can really start honing in on that question and getting really clear on what I'm trying to answer. So the population I'm interested in is adults, and I've chosen a range of 18 to 60. And the intervention that I'm interested in is smell training, which I've just described. And I'm going to compare that to standard post-COVID-19 care. And the outcomes that I'm interested in are actually regaining the sense of smell And I looked, and there are two validated tools for measuring sense of smell. One is sniffing sticks, which is a 12-item questionnaire which involves sniffing 12 different sticks, pens. And there is another one, which is the University of Pennsylvania UPSIT test, which has 40 items, which I thought was a bit long for this short study. So I went for sniffing sticks, and the time frame I was interested in was really a little bit longer than the acute period. So I wanted to check whether the sense of smell was regained after 3 months of symptoms. So you can see now I'd got really clear about my research question, and I reformulated it to this. Does smell training, the intervention, improve sense of smell, the outcome, at 3 months post onset of symptoms, the timing, in adults aged 18 to 60 with anosmia, the population, following COVID-19 infection, when compared to standard care, the comparator? So now I've got this question, which is really robust. So if you came across this on a journal article, you'd know exactly what that study was going to show at the end of it. I mean, you wouldn't know the results, but you would know what I was looking for at that time. Once you've got that question grilled down to that PICO framework, then it's important to ask yourself if it's feasible to run this study. So these are the criteria called the finer criteria. Is it feasible to do smell testing in patients who have had anosmia after COVID infection? Well, I think it's pretty feasible. It's not a very invasive procedure or anything like that. So I thought it was feasible. Is it interesting? I feel it's interesting, especially for people working primary care in ENT. I think that would be very interesting for them. Is it novel? Well, I've looked online and it is novel and it hasn't been done before. So if anybody ENT or primary care doctors out there want to do this study with me, please get in touch. Is it ethical? Well, I'm sure that there are some people who might have allergies, for example, to essential oils, but in general, it seems like quite a safe procedure to do. And is it relevant? Well, highly relevant during this time because so many people have lost their sense of smell or taste and some haven't regained it. So I think it meets the finer criteria. So now we've got our research question, now we can start thinking about the study design that best answers this question. And study designs are numerous. I'm just going to outline these very broadly into two different categories. There are more. There are observational studies and interventional studies. Observational studies tend to look at incidence or prevalence rates. They might look at diagnostic tests and whether they're sensitive and specific, and they might look at the risk of getting a disease or outcome. Whereas intervention studies involve an actual intervention, such as a drug or a technology, and they're comparing the efficacy, which is whether it works in a very controlled setting, or the effectiveness, whether it works in a real world setting. So observational studies can be a snapshot, a cross-sectional survey. So I could do a snapshot of everybody in Oxford who has symptoms of anosmia at this moment, and that would be a cross-sectional survey. A cohort study, which is looking at a group of people and monitoring them throughout time, either prospectively or it can be done retrospectively. As well. It's often quite time consuming to do prospective cohort studies, and case control studies, which are really good for rare diseases where you can compare those who had a disease with those who didn't have the disease. With all of these, there are other factors that can influence the pathway between the exposure and the outcome, and these are called confounding factors. So you can't always prove causality in observational studies. Interventional studies are really looking at whether something works in an ideal setting, its efficacy, or if it works in a real world setting, is it effectiveness, and if it's safe. And generally there are two types of interventional studies, non-randomized, which you sometimes can see in journals as described as quasi-experimental, and also randomized studies, which are either clinical trials or implementation trials. The advantage of randomizing people or participants during a study is that it can reduce the systematic error in a study, the bias. And that's because the different characteristics of the participants can be evenly or randomly allocated to either a treatment group or a control group. And we can also conceal who's been allocated to which group, but through allocation concealment and blinding. And we can also follow up those who've dropped out of the study, and look at their data at the end using intention to treat analysis. And all of these reduce the systematic error, so they're more likely then to show a link between the actual intervention and the outcome. To reduce the random error in these types of studies, it's really important to adequately power the study and to get an effective sample size. So, a really excellent resource for all of these types of studies and methodologies is the Equator Network. And if you don't take anything away from this talk, I hope you take away this and go ahead and look at this website, because it's got all the different types of studies, how to conduct them, the checklist, so you know exactly what you need to do for each of these types of studies. So it's a really excellent resource. So going back to my research question, which does smell training improve sense of smell at 3 months post onset of symptoms in adults aged 18 to 60 with anosmia following COVID infection when compared to standard care? So which study design shall we go for? Well, we've definitely got an intervention there. Smell training is an intervention. So it's going to be an intervention design, an interventional study. And it's really then to decide whether we should randomize or not randomize. And since randomization, I know, will help reduce systematic error or bias in the study, then if possible, I would like to randomize these patients. So based on this research question, which has an intervention in it, I'm going to look at the different types of interventional studies. If the research question didn't have an intervention in it, I might think about observational study designs as well. So I've decided to go for a randomized controlled trial. So once you've got your research question, then the rest of the study design and everything that comes after it can follow. So we haven't got time to go through all of the rest of the steps in this today, but I hope that this has been really useful for you. From designing the study, then you look at the methodology and what type of data you collect. You look at how you collect the data and store and analyze it through data management plan, getting ethical approval, and then actually writing a study protocol and writing for publication through reading journals and author submission guidelines and getting an idea of what is publishable. So these are the 10 steps that I think are really important when discovering a research question. We've got as far as step 5, and I hope that in the future we can carry on those 10 steps and go through the rest of this in more detail. Whenever I think about what is an important research question, I always go back to this quote, which is, whenever you're in doubt or when the self becomes too much with you, apply the following test. Recall the face of the poorest and the weakest man who you may have seen, and ask yourself if the step you contemplate is going to be of any use to him. Will he gain anything by it? Will it restore him to a control over his own life and destiny? In other words, will it lead to Swaraj, independence for the hungry and spiritually starving millions? So I hope that this talk has given you an overview of how to discover the important research questions in global surgery and how you might go on to formulating those research questions into study designs. Thank you very much for all your time. Bye.
Thank you so much, Shobi. That was a wonderful talk, and terrific to have ENT as a global surgical problem. I'm really delighted. We're moving on swiftly to our next interview with Dr. Dr. Godfrey Sam Philipo, who's a global surgery researcher working in Tanzania.
We're excited to introduce Dr. Godfrey Philipo for this special episode for the Oxford Global Surgery Conference. Godfrey has bridged the gap between being a medical doctor and a public health specialist as the clinical research coordinator for two main projects, looking at improving cancer care in Tanzania and addressing children's surgery in Tanzania. He's also previously served as a co-founder of Incision and was on the board of trustees for this organization. We're excited to welcome Godfrey to the show.
Thank you, Rihanna and Taylor, for hosting me.
Thank you, Godfrey. Now, for our first question, having a strong clinical research capacity in LMICs is crucial for global surgery. How did you decide to go from being a clinician to being a full-time public health researcher?
Okay, thank you, Rihanna, for that question. So for me, I feel like it's the route was not a bit direct. So maybe the bigger impact was from my medical school, where I joined the group of medical students. And then when I went for my master's in China to do the master's in public health, that created a more understanding of the global burden of diseases, but specifically merging with the global burden of surgical diseases. So through mentorship, through my peers, that gave me the understanding of global surgery. But then my understanding in public health and medicine gave me that opportunity to be able to understand the two. But then the nature of the work that I got after graduating, that was having a bigger impact. So I got employed in research, and I was definitely working on on cancer research. That gave me more time to think about myself, but then to see more how I can contribute, even if I'm not a surgeon or if I'm not a clinician. So I can contribute in research, in producing good evidence that can help people to do better in cancer care, but also in this new burden, the global burden of surgical diseases.
I think that's so great. I love that we're talking about this and the impact that different people can bring to global surgery. We've talked about this before, but it really does take an army of researchers, of people building hospitals, funding them, technicians to run the machines. We're all a big team to run this, and so it really takes a lot of time and effort and people with different skills to do that. So we really appreciate all that you're doing with the research. And one thing that we do want to talk about with your research is obviously COVID-19 has changed the face of really global surgery in the world around us. And so how has COVID-19 really affected your research, both in the positive and in the negative manner?
Okay, so I can start with the negative because that is the bigger part of it. So
Sure.
for me, who is working in research, we had to stop a number of research projects so that we can allow a room for clinicians to work with who work with patients to have and also to reduce the exposure of so for the researchers who really doesn't take care of patients. But then a number of research that I'm working on, and maybe a number of schools, the number of projects that are being involved require training. So COVID-19 and most of the training are done by a collaborative team through these partnerships. So people couldn't travel to come or go to receive other training from other countries or from other people, but also the number of patients, especially those with elective cases, had to pile up. There was a big backlog for patients because mostly, since the number of clinicians it's minimal. The workforce is not that much in Tanzania. So, and then the most were much involved in COVID. So even the number of cases were reduced. So even the patient didn't have enough access to surgical care, I can say. So those are the few, but I think the other, maybe the impact in clinicians themselves. It's a new disease which created a bigger panic among people. So it brought a number of negative impacts. In the positive impact, very few, but I think we got an idea to reinvent ourselves, to think of other ways for example, to handle training, going from on-site to online training, also trying to find a way where we can communicate, we can make sure all the things that we are working on are moving through the online using technology. So we got to think, I can say, to try to make sure that life goes on as usual. Although it is not usual, but I think at least we get to adapt to a new way of living.
Absolutely. And I think that's probably one thing that we can take from this whole period of the new normal, which is how to connect in a different, more virtual way. And this probably leads into our next question, which is just about the interaction between high-income country research centres and LMIC research centres. Obviously, this whole wave of online technology being used in research and teaching must have impacted research, but also how can we use these sort of technologies to go against this paradigm of HIC researchers being accused of extracting data from LMIC centres without necessarily adding value to their LMIC colleagues?
So my thinking is that most of the partnership are being formed, and people who form the partnership know each other, they know what they want to do, and coming up with ideas, coming up with research projects, it's a mutual understanding. But this one has a bigger impact in trying to make things in line, trying to make sure that everybody, and whether it's high income or low income, everybody benefits from that research. And also the most important, I think, the patients benefit out of it. And I can say another thing, maybe the institution themselves and the government, the review process in a number of countries, that has a bigger room and a bigger impact in trying to make sure that everything goes on ethically, but then trying to have a balance that this kind of research is of importance in this country, or this one is not. So the oversight of the government and the institution is really important. But then the people themselves, I think they take a bigger part in trying to understand what they want and what impact they want to bring, and that has to come up in a mutual discussion and mutual understanding among the people who are involved in the partnership.
Thank you. I think those are some really good points and things that we need to be thinking about, especially when we're working with governments as well. So just in our last couple of minutes, could you just tell us maybe one thing that you would tell LMIC researchers when they're trying to set up their own initiatives, something that they should be aware of?
I can say one thing is to try to understand that it's not easy. We need to learn every day. We need to learn about the content of the research that you want to do. You need to learn the interpersonal communication among people, because most of the research are being done and funded when you have a collaboration. And then they have to be ready to learn and learn and learn without stopping. But the most important thing is to find a mentor. It doesn't mean that a mentor has to be someone with a bigger understanding, a bigger knowledge of the subject, but even the peer people meet and talk and try to discuss, you can learn something out of that and be able to establish a research.
Thank you so much, Godfrey. I think that's great advice, to try and find like-minded people and learn from them. And I think that mentor doesn't necessarily need to be senior, like you said, but just someone that is able to inspire you and guide you and just give you that advice. And certainly, I'm sure it's a two-way street with people bouncing ideas off of each other. So we appreciate you speaking to us today about your experiences with COVID-19 and research, and just about global surgery research generally with what you've been doing. So thank you very much.
Thank you, Rihanna and Taylor. Thank you for having me.
Well, thank you yet again. But we now welcome Dr. Anant Jani to speak on prioritising resource allocation in COVID-19's potentially disastrous aftermath. Anant is another member of our global surgery group and works in the Oxford Martin School as a research fellow in the value-based healthcare programme with the Department of Primary Care Sciences here in the University of Oxford. He's got a PhD from Yale and is interested in understanding how to improve population health by addressing social determinants of health and using social prescriptions. So over to you, Anant.
Thanks very much, Tony. So I'm just going to share my screen. Okay. So my talk is going to be a little bit different from the other talks in the sense that firstly, I'm going to take a much more systemic view, number one. And number two, I'm going to start talking about COVID-19's aftermath. So unfortunately, many countries are still dealing with the pandemic. There's probably going to be a second wave as well. And we're uncertain about all of these things, as Hilary pointed out in her great talk. But it's important that we start planning for the aftermath. And it's also important that we start thinking about how we allocate our resources, not just our surgical resources, but our healthcare resources and our societal resources more generally. So before I get started, what do I mean by resource? So in a surgical context, a resource will be money, but it would also be the use of surgeon time, the use of surgical beds, of anesthetists, of medications, et cetera, all of the items needed to actually deliver a surgery. And when we're thinking about even the COVID lockdown and the COVID aftermath, when resources will be really constrained, it's important that we allocate our resources for the maximum benefit of the population that we're accountable to minimize their suffering. So to get started, let's look at the 2008 global financial collapse. It wasn't a healthcare disaster, but it was probably one of the closest systemic shocks that we've had at a global level in recent years. And the lessons that we learned from the 2008 global financial collapse, again, despite it not being a healthcare crisis, was that it had massive impacts on health. People were unemployed, they lost their income, there were massive reductions in well-being across the world. And one of the things that we found from the 2008 global financial collapse, again, being able to look in hindsight, is that it led to inequality, social fragmentation, unemployment, debt, worsened standards of living. And a lot of these have longitudinal and transgenerational consequences in the sense that the recovery is going to be slow. And we found that particularly in resource poor settings, many people got stuck in a poverty trap. And again, this has transgenerational impacts, not just on that individual who is facing poverty, but their children and their grandchildren, et cetera, particularly in resource poor settings, because it can have impacts on nutrition, mental health, et cetera. Now, this is something that Hilary touched on when she showed her roadmap, which is we don't really know where we're going in terms of COVID-19, and there's a lot of unknowns. And the way we can contextualize this is to realize that we're living in a complex and nonlinear system. And basically what that means is we're living in a time and a situation that is completely unpredictable, number one. And number two, it's irreversible. And this is, for the 2008 global financial collapse, sort of captured in this snapshot from the UK. So it basically took us 4 years to get back to some semblance of normality. And the 2008 global financial collapse largely and predominantly affected the real estate sector and the financial sector. It didn't affect all the other sectors, whereas the COVID-19 pandemic has basically affected all sectors and all aspects of our society. It took us 4 years in the UK context, where there was a lot of public investment, to come to some semblance of recovery from the 2008 global financial collapse. COVID-19 is likely going to take us much, much longer to recover from, and some countries, unfortunately, may not recover. What we need to think about in this context is what can we do to increase the chances of our countries recovering and reducing the suffering of our citizens? And how do we allocate our resources to do just that? Now, if we go back to this notion of a complex system being unpredictable and irreversible, this, I don't know if there are any physicists in the audience, but this is called a hysteresis curve. And basically, when you're looking at a complex nonlinear system, you'll have a stable state. Now, just one really quick point, just because it's stable doesn't mean it's equitable. So there will still be imbalances and there will be inequities and inequalities, even though you're stable. But in the pre-COVID state, we had a stable, steady state. COVID-19 destabilized everything, and it is continuing to destabilize things and our society. And that's going to lead to the establishment of a post-COVID aftermath that will generally and gradually become stable when different pieces sort of fall into place. Now, that stability can either exacerbate inequalities or, as I'll sort of address later on in the talk, we can use this chaos and this instability to try to make things better. And many of you have probably heard this notion of build back better and Green New Deal, et cetera, et cetera. So this is, I think, a notion that we should be trying to push forward as much as possible. Now, this is just a random network diagram. And again, this is getting to this notion of why a complex and nonlinear system is difficult to predict, because these elements are sort of related to each other in different ways. And if you move one element or take one element out or shift another element, you don't know what the ramifications are going to be on all of the other elements within the system that you're working on. And so this is the so-called butterfly effect. Now, just because we're living in a complex nonlinear system that's unpredictable and irreversible doesn't mean that we can get away from making decisions. And so when you're in this type of complex system that's unpredictable and irreversible, how do you actually make decisions? And this is where the work of Gerd Gigerenzer at the Max Planck Institute has actually been very helpful across the world. And he uses some of the work of an economist called Frank Knight, where you basically try to distinguish decisions that need to be made in situations of risk versus fundamental uncertainty. And Anita touched on some of these things in some of the guidelines and the actions that she outlined. So a situation of risk is a situation where you know all of the outcomes as well as the probabilities of each outcome. So for example, if event A happens, there's an X% probability that event B will happen. You know how those two variables are linked, and you can make a prediction. If A happens, then it's this likely that B will happen. In a situation of fundamental uncertainty, some of the alternatives and outcomes, in addition to the probabilities, are going to be unknown because we don't know how the different variables interact. And as you saw in that network diagram, as things move and shift within the network, you don't know how things are going to rebalance themselves in the system. And so you no longer have a clear idea of how the different variables interact. And so this, sort of again, going back to Hilary's roadmap, which I thought was very helpful, gets us to a very basic and fundamental question, which also ties into some of Shobi's questions about, what you should be researching. What do we know and what do we not know? And you can have this very basic, very, very basic matrix in your mind. You have known and unknown on both the rows and the columns. And you'll have your known knowns, you'll have your known unknowns, and you'll have your unknown unknowns. And so, what does this gibberish mean? So if we go to known knowns, this is a situation of risk. For example, you'll know the number of people in your ICU with COVID-19, assuming that you have accurate COVID-19 tests. You will know the number of people in your ICU with COVID-19 who recovered or died. You will know the number of people claiming unemployment in your society. You will know the number of people needing or claiming housing benefits. Then you have the known unknowns. This is something that you know you could actually capture if you had the right data and the right mechanisms of capturing that information, but currently you don't know it. So basically the known unknowns can be reduced to risk if you have systematic data collection. And so what would be examples of this? This would be the total number of people infected in your population, the total number of people with immunity, assuming we have a valid and accurate antibody test, when the second wave will hit. And that you can start capturing by looking at daily incidence numbers, the total number of unemployed, the total number of people going hungry in your population, for example. And then you have the known unknowns. And this is a situation of fundamental uncertainty. You have no idea what's going to happen. So in the situation of fundamental uncertainty, how do you make decisions? So what Gigerenzer suggests is, this very basic quote: as you do not fight fire with fire, you do not fight complexity with complexity, because complexity generates uncertainty, not risk. It requires a regulatory response grounded in simplicity, not complexity. So basically, you should try to take simple steps that you can monitor over time. And from a health perspective, you should try to take the steps that will allow you to allocate your resources to reduce the suffering of your people in your region, in your population, in your society, in your country, etc. And so if we think about COVID-19's aftermath, where are going to be the greatest sources of suffering, and where should we be thinking about allocating our resources? Well, if you look at general work around social determinants of health and health, population health, etc., where we define health as length of life and quality of life, and obviously there are debates as to whether those are the best two measures, but they're at least semi-quantitative, and it's something that we can systematically collect. You can see that clinical care, i.e. access to doctors, nurses, physiotherapists, medications, etc., account for about 20% of health outcomes. 80% of health outcomes are due to other social factors related to health or social determinants of health. Health behaviors like tobacco use, diet and exercise, etc. Social and economic factors like education, employment, income, etc. And physical environment, air and water quality, housing and transit. And what we're already seeing, so if I take the UK, I'll take the UK as an example here, because we've had our first wave, we might be now onto our second wave. But we're already seeing a dramatic increase in social need. So these are just some headlines. I'm not going to read these all out to you, but we're seeing a widening in educational inequalities. Jobless claims have jumped to the highest that we've seen in a long, long time. 3 million people went hungry during the lockdown. And there is a suggestion, or the projections suggest that the number of people going hungry will increase even further post-lockdown. Problem drinking has soared. Domestic violence has also increased. Domestic abuse killings more than doubled during the COVID-19 lockdown. And so, again, thinking about the aftermath, and even thinking right now in terms of the lockdown, a fundamental question that you can ask yourself as a healthcare professional, not just as a surgeon, is what will cause your citizens to suffer? And there are a few basic things that have sort of been proven time and time again. Educational failure, insecurity and unemployment, housing standards, stress, social exclusion, early life, addiction, food, transport. So all of those other factors, the social determinants of health that you saw in the previous slide. And so again, coming back to this notion of how do we prioritize our resources, our limited resources, where every decision that we make now will have implications now and in the future because of the transgenerational effects that we're going to be seeing in this very chaotic system. We turn to Geoffrey Rose, who was an epidemiologist at the London School of Hygiene and Tropical Medicine. And he wrote this fantastic paper, which you can access here, which is looking at sick individuals versus sick populations. And what he talks about is the high risk approach, i.e. looking at individuals who are at high risk of morbidity and mortality, versus looking at the population approach, where you actually try to control the causes of incidence of disease in your population. And he has this very simple heuristic diagram where on the x-axis, you're looking at the risk of your population. On the y-axis, you're looking at the proportion of the population that actually gets sick. So when you look at this diagram, most healthcare systems focus on this high-risk group. And that will be true for surgeons as well. And why? Because they're high risk. But if you look at aggregate morbidity, mortality, and spend, it's always in this medium risk group, because though they're lower relative risk, there's a higher absolute number. So the number of events in this bubble will always be higher than the number of events in this bubble. And the aggregate morbidity, mortality, and spend in that middle bubble will always be higher. And what Jeffrey Rose advocates for is, from a population health perspective and looking at building healthy societies, our focus should be on shifting the entire population distribution, the risk distribution, to the left. And there's a few things that happen here. One is you'll see that you're now your highest risk group is in this medium risk category. And that's important because the level of intervention you need as you go to the right will increase. So for the highest risk group, you will need a higher level of relative intervention compared to the medium risk or low risk. This is not to say in your low risk group, you need no intervention to keep them healthy. You will, but it won't be as costly or as resource intensive as a high risk group. And so what we're looking at here is just a very, very basic notion of shifting from short-term symptom management to long-term prevention and health promotion. Now, if we think about this from the COVID-19 context, thinking about the context of Haiti and low and middle income countries, and some of the morbidity, mortality statistics that we're seeing, most of the people that got sick and who died from COVID-19 actually had pre-existing conditions, many of which were non-communicable diseases, which could be brought into remission and reversed. So from a population health perspective, you can actually build a healthier and stronger, more resilient society by ensuring those individuals are healthy so that they're not as susceptible to COVID-19. Projecting further, COVID-19 was completely unpredictable. People predicted that there will be some sort of pandemic and epidemic, et cetera, but nobody knew it would be COVID-19. Nobody knew when it would hit. Nobody knew what the global implications would be. But now we've seen what the implications could be. And if we take ourselves back to the 1918 Spanish flu pandemic, those are really painful lessons to learn. And there's nothing saying that we will not have another pandemic. But what we can say is that if we had a healthier and stronger population, they will be more resilient and resistant to infection. If we take this from a surgical resources perspective, particularly in low and middle income countries. So if we go back to what I mentioned earlier, you have a limited and finite set of surgical resources: surgeons, theaters, operating beds, medications, gauze, nurses, etc. And those resources should be allocated to the individuals for whom surgery cannot be prevented, i.e. the ones that are at the highest risk. Now, when you're thinking about societies in general, and particularly in low and middle income countries, you see things like electrical burns because of exposure of wires, right? This is something that's completely preventable, not from a surgical perspective, but from a policy perspective. And this is something that you can start thinking about in terms of this notion of building back better. Road traffic accidents. These are preventable, right? If people are safe, wearing seatbelts, wearing helmets, if they're on the scooters or motorcycles, these things are preventable. And that would mean that you're able to shift your risk profile to the left, and you will get the maximum impact for your population and your citizens with the limited amount of surgical resource that you actually have. And so again, this notion of building a stronger society in COVID-19's aftermath. This is a tool called quincunx. And basically it's, you have a funnel with marbles at the top, and then you have a bunch of pegs, okay? And you have containers at the bottom. Once you start letting the marbles go down, for whatever reason, the marbles always get into a normal distribution. What implications does this have for us in COVID-19's aftermath? Well, we can start rearranging these pegs so that we can build a stronger society post-COVID, looking at the structural elements that lead to the suffering of our citizens: housing, jobs, education, transport, food, air, water. And that takes us back to this notion of reducing the entire risk profile of our population so that we can make our limited health resources go as far as possible. So that's all from me, and I will turn back to Tony.
Well, thank you, Anant. We've heard 4 of our team speaking, the Global Surgery Group speaking, and you can, I hope, join with me in thinking what an outstanding collection of talks they were. It's what every Thursday morning we get challenged with, thinking at this high level. So they're a delight to work with, and I've really enjoyed their presentations this afternoon. Move on to our third interview, and that's with Dr. Marc Dubois, the former Executive Director of MSF, Médecins Sans Frontières, Medicine Without Borders.
Prominent figure within Médecins Sans Frontières, MSF, or Doctors Without Borders, after having worked with them for nearly 15 years, which included his role as a general director of the UK section. He is also a lawyer and has worked with the US Peace Corps. And with that, we'd love to welcome Marc Dubois.
Hi, pleasure to be here.
From your background, you've written extensively about humanitarian and development work. Would you mind just walking us through your journey from civil rights litigation to General Director of MSF UK to now being an independent analyst and writer?
Yeah, it's a bit of a zigzagging path, but I'm going to go before being a lawyer. I started right after the university as a Peace Corps volunteer. I worked in rural Burkina Faso doing rural development work. I was raising chickens and things like that in rural communities. And what I came away with was a sense that this isn't about technological transfer. This is about politics. And I got a master's degree in development studies and focused on the politics of development studies. And again, it went a little further, and it said something about it's about rights, right? It's about empowerment. It's not about we need to teach these people how to raise chickens. There was no point in me teaching people how to raise chickens when they didn't have the right to own land and things like that. So I went to law school. I studied international human rights, international law, things like that. I did do civil rights work in the United States for a few years, but I missed the international. I missed being part of that big world, and I felt as if my Peace Corps skills weren't being used. For instance, being able to speak and work in foreign languages, things like that. So one thing led to another, and a former classmate of mine from law school was with Médecins Sans Frontières, and I called her up and ended up 15 years in the organization. And I think underneath that sort of trajectory, and it really is a bit of a zigzagging with some bartending and a lot of other things in the middle, but underneath that trajectory is an idea that power matters and power dynamic matters, and understanding what's going on and not what's on the surface, but what are the underlying drivers and the culture and the processes and the structures that result in what we see in front of us and the problems we see in front of us and the problems that we're trying to address. And the second thing that runs through that is a bit of trying to escape from the moral complexity of things. I was looking, and I'm sad to say it, I was looking to be a savior. And the development world was morally complex. I couldn't figure out by the end of my Peace Corps thing whether we were doing more harm or more good there. And I rather naively got into humanitarian action because I wanted something a bit more pure. You're just saving a life. What could be less political than that? And of course, in my years in MSF and certainly since then, I've really come to doubt how morally simple that is. I think it's actually a very morally complex, field of work. So that's where I am.
It's a really exciting journey from both your personal experience and also probably a little bit of serendipity, meeting that friend along the way who led you down this path.
Much serendipity along the way, yes.
I think it's really interesting what you said, in that you specifically studied the politics of development studies, and you mentioned how this is a really difficult field within humanitarian aid work.
And how politically neutral aid organizations should be is an issue that many aid organizations do contend with. And where do you stand on this issue?
Yeah, neutrality is a really interesting question. It's one of the core humanitarian principles, and I think that aspect of neutrality, the rather basic definition, is look, you wouldn't let anyone come into your house if they were going to do something against you, right? If they were on the other side of some conflict, and in particular in a conflict situation, it makes a lot of sense that if you want access to people, if you want to go and to be able to deliver aid and assistance and protection to those most in need, you need to have access to them. And you're not going to get access if people think that you are operating in the furtherance of one of the sides of a conflict, right? So that, I think, with that in mind, and if you look around the world in places, in the Middle East, in many places now, in sub-Saharan Africa, in certain wars, if you don't have that neutrality, you're not going to get in. You're not going to be able to access those most in need. I think that the more complex parts of neutrality can be, for me, they're twofold. One is, what does that mean in terms of neutrality towards victims, towards people suffering, towards populations in crisis, right? Are we neutral towards those who are on the wrong end of abuse and violence? When a hospital gets bombed, are we neutral to that? And I think that's a real question with aid organizations of how do you engage with that, with maybe even solidarity with people who are in crisis, and at the same time maintain a proper level of what you might call political neutrality vis-a-vis the conflict in order to maintain your access. And that's very hard. And I think it's very hard for organizations, but it's also very hard for individuals. I think at a certain point, individuals have to make their own choices on that. And a third area, and one that doesn't get talked about much in the sector, and that I think is coming, is what about the neutrality towards what we're actually doing in a real big picture? And the reason I say that is, look, no one would expect an organization like Médecins Sans Frontières to take money from the tobacco industry or the defense industry, right? I mean, you can't take money from the defense industry to go clean up the mess they make in some other country, right? But what does that mean when a lot of what's going on in the world today is the result of inequality and social injustices that aren't just being perpetrated by, let's say, a defense industry or some, it's a lot more complex. And a lot of our donor money does come from, across the aid sector, comes from governments and comes from major corporations and comes from people who maybe aren't so neutral vis-a-vis these underlying structures of inequality and injustice. And what does that mean? And I think that's a much harder question for us. And a much harder question when you start thinking about, are we neutral to the unintended consequences of our aid? What if our humanitarian aid means that people don't try and fix the other problems that are going on, right? We're just putting Band-Aids on things. I think of humanitarian aid as very much a response to people's immediate needs, but not fixing the underlying structures. And what if we're a bit of an alibi? Are we neutral towards that? So, I mean, in some ways, people have told me I get paid to complexify things, and that's a complex way of looking at neutrality.
It is just a really difficult subject, and I think exactly what you say is true probably for the healthcare workers, in that there's a difference between the people they're seeing on the ground and that sort of instinct to help others, and then trying to separate that and disentangle that from, like you said, the political structures that are funding their work and also that are causing the humanitarian organization to be required in the first place.
Yeah, that's exactly right. The purity of the act is quite simple, right? Whether you're sewing somebody up in your surgery, or whether you're reaching a hand out of a boat to pull somebody out of the water, or providing food to somebody who doesn't have enough food, that's very simple. That's as human and a manifestation of human compassion that is absolutely gorgeous. But it's within a context, and that context is complex and gives meaning to it that you have no control over. And that's what's hard.
Absolutely. And I think you've described a really complex topic really well in just a very short period of time. One thing that you mentioned earlier was this whole idea of power dynamics, and that's something that does come up quite a lot. And within the aid sector, how do you think that they can find the balance between providing aid and supporting the local health infrastructure sustainably without undermining the role of the state?
Yeah, the aid sector has been asking itself that question for a long time. And one of the problems in the aid sector essentially is that it doesn't really control what it does. There are a lot of a lot of the aid sector is dependent on what donors will give money for, right? And to a certain extent, the aid sector 20 years ago said we need to be more accountable to people on the ground, and it's still struggling with that. Everyone in the sector agrees with it and yet can't deliver on it. Or we need better community engagement from the humanitarian standpoint. We can't just show up to places and do stuff. We need to talk and engage with communities. And over and over and over and over again, the community gets left out, right? And if I'm speaking in very critical, broad brushstrokes. Of course, there's community engagement that goes on, but by and large, this is a real sticking point. And what I'm getting at is I actually don't think that the sector can do much here. I think that balance that you asked about has to come from the outside. You know, if you think about balancing on the scales, I think the sector is kind of lost on its own scale in this. And it actually is for communities and for governments and for other actors to impose some balance, to take some balance on the humanitarian community. And this is a very difficult thing. You know, it's hard to get that balance when you don't have that much control over what humanitarians do. But that for me is the only way the balance is going to come. It's not about what the aid sector does. It's about what the external world to the aid sector does that will create better balance.
Thank you so much, Marc. I think we really learned a lot today and talked about some really important topics. And so for those of you who would like to hear the rest of the episode, you can check out globalscalpels.com or get on iTunes or any of your favorite podcast episode players and be able to listen to the rest of this episode. And we thank you for joining us today.
Well, thank you very much, Global Scalpels. Thank you, Rihanna and Olaton. That was most interesting. And I hope all of you who are watching this conference have found the afternoon useful, informative and stimulating. And if you'd like a certificate, please let us know via the facility column on YouTube, and we'll email you one. And just to wrap up, I'm delighted to introduce my good friend and colleague, Professor Ashok Handa, to chair the speaker's response to some of your questions. Ashok's a vascular surgeon in Oxford and leads on the surgical content of the undergraduate curriculum. In addition, he's made a long-standing and invaluable contribution to surgical education for postgraduates here in Oxford, in the United Kingdom as a whole, and globally. And we're absolutely delighted that he's been agreed to chair this session. So over to you, Ashok.
Well, Tony, thank you for that. Probably time to retire on the basis of that, although not all I think I can take credit for. Look, we've had an amazing set of talks. I have to say, I've learned so much today that I'm going to insist on spending more time with the speakers in our termly meetings. But we have got some questions from the audience for you, and I've got one or two from me. And Hilary, maybe we could kick off by saying that anaesthetists are very scarce and in the line of direct exposure. Do you think there's a better way to protect them in cases where PPE is insufficient?
Well, thanks very much for that question. It's a really good one, and it's been on everyone's minds all over the world. And I think there are other ways. I mean, clearly getting PPE to places and sourcing it is important. But there are other mitigating factors I think we can take into account. We're fairly confident now that some procedures anaesthetists take are more risky than others, those that we call the aerosol generating procedures. So in our normal lives as anaesthetists, there are going to be ways we can minimise our exposure through minimising AGPs. There's lots of ways to give an anaesthetic. So, for example, taking on more regional anaesthesia versus general anaesthesia or local anaesthesia. Of course, we've been in many places very well supported by surgeons who found ways to do things and manage patients that don't involve general anaesthesia as well, for which we are genuinely very, very grateful. And then I think there's also environmental issues. So thinking about the ventilation and the direction of ventilation in rooms where AGPs need to be undertaken. And then there are a number of innovations around the idea of perspex boxes trying to screen anaesthetists from droplets, especially around airway management. And a particularly interesting one I saw that's been developed by a team in India, using normal operating room suction in the box to essentially develop a small negative pressure area just around the patient's head. So there are environmental mitigators, and I think thinking about how we work and what we do and what we don't do, as well as thinking about the environment, is helpful.
Thank you, Hilary. Lots of really good ideas there. Shobi, there's a question for you saying, do you think that home-based care will continue after the pandemic, or will people just go back to behaving as they did before? I don't know if Shobi's online for that.
Thank you, Ashok. Thanks so much for the question as well. I actually think home-based care has been going on for a long time in other parts of the world. For example, in India and sub-Saharan Africa, community health workers are a part of the health system, and so home-based care is practiced globally, and I think it's something we can really learn from during this pandemic. And certainly there are people who actually prefer to be in the comforts of their homes and have remote consultations. And following on from that, we just need to think about how we best deliver those needs to people who aren't able to leave their homes at this time. And along with that comes infrastructure in terms of technology and data protection, but also protection for healthcare workers and support to actually navigate these new technologies as well. So I definitely think that home-based care has a role in this pandemic and beyond. And I think there's a lot we can learn from other countries on how they've actually been doing this for years.
Thank you. So Anand, there's a question for you from Mihir, who says, well, thank you. How can he as an individual, or how can any of us as individuals make differences on this system level scale that you so wonderfully described?
Thanks for the question, Mihir. So as a starting point, keep yourself healthy, because that will make you resilient, and it means that you'll not potentially be somebody who needs to use healthcare resources when they're so limited. So I think from an individual perspective, I think that's a key thing. And then I suppose the other thing is just the civic responsibility. So, you know, again, going back to sort of political science and thinking about the social contract, and maybe some of the stuff that Marc Dubois might bring up as well. What is your civic responsibility, and what is your responsibility to yourself, to your neighbors, and to your community as a whole? So if you identify something that is going wrong and that could be fixed, then you should take it upon yourself to actually be vocal and try to get it fixed. It may not be quick, but if you keep trying and gather support for it, then it will happen. So, you know, if we look at England or the UK as an example, and if anybody has read Dickens, Victorian England was not such a great place. Child labor, low life expectancy, etc. But Clean Air Act, Clean Water Act, you had John Snow looking at and doing the work on cholera, better housing standards, etc., etc. That happened over decades through individuals acting and getting ideas and then galvanizing groups. So for any society or any context, I think this is a similar notion that, you know, what we see right now in Western countries didn't always exist. It was designed, planned, and built. So as an individual, keep yourself healthy. And then from a societal perspective, identify the things that are going wrong and act, basically. Not going to be easy. It's not going to be quick. But yeah, that would be my...
But we certainly won't get there if we don't start. Sure, thank you. Anita, a question for you that, you know, you pointed out that beautiful slide, the poor access to water, let alone clean water, and so in low middle income countries. And where do you think we are with the WHO Clear Water Project, which over 20 years was going to get clean water all over the world?
Yeah, no, I mean, access to water is absolutely basic, isn't it? And And yet, I think in many, certainly rural parts of sub-Saharan Africa, Southeast Asia, etc., it's still a basic that is not there. And unless we can think, as Anant says, looking at systems and what systems matter. I thought it was very interesting, his slide where he talks about actually the clinical outcome, the 20, we're contributing 20% to people's well-being, but obviously because we're medics and we're there and we're doing it, we think it's really important, but actually, if someone doesn't have running water at home and clean running water, then they're not, not going to stand a chance of remaining healthy. So these absolute basics like clean running water, safe place to live, access to nutrition, and so on is absolutely vital. And yeah, I mean, I think we need to rethink that a little bit. The complex stuff is so far down the line. It's just the basic stuff.
And just to follow up on that, I mean, is the same issue of access to water and poverty why we're seeing these huge increases in some parts of middle and high middle income countries, certainly middle income countries?
Sorry, just repeat the question.
We're seeing these local centers of high incidences of COVID.
Yeah.
And is the same issue around access to clean water or sufficient quantity of it? Because people worry about paying for their water.
Yeah, I mean, the high incidence of COVID in the high income countries is probably more to do with the demographics and also the fact that we're testing now for it. And so when we talk about this second resurgence in the high income countries and so on, I think, we're just able to test now and actually see the virus, whereas before we were just seeing the effects of the virus, which was the symptomatic people and the people who then died from it. And obviously now, we have mechanisms to try to prevent the spread, and so we're more aware of washing hands and even the asymptomatic spread, which we were sort of not really paying so much attention to. And so we see these huge, the resurgence, but actually not the same in terms of numbers of deaths. But I think that we're just better at monitoring and better at preventing the spread, but it doesn't mean that it's not there. And so my general feeling, I know Hilary talked about possibilities of sub-Saharan Africa, there being a different kind of strain, or the way genetically people are responding to it, that could also be playing a part. But for sure, data is key to it. And I think we just don't have the same level of data in low middle income countries, and also affecting the most vulnerable, so that poorest quintile that I talked about.
Sure, thank you. So a more general question is around, is it worth us recognizing the learning from sub-Saharan Africa about how to effectively manage an infectious disease? So what have we got to learn from LMICs, and in particularly sub-Saharan Africa? I don't know who wants to take that question.
Yeah, I wouldn't mind just pointing out, I'm reiterating what I said in my talk, but I thought it was fantastic. If you don't listen to the Director General, WHO Director General's updates, they're twice weekly now, but on one of them, he brought in the head of the West African region for the WHO after they just eradicated Ebola in Congo, and said, how on earth did you manage to eradicate Ebola in Congo whilst there's a civil war going on, never mind the issues of lack of access to, water or sanitation, or access to health, posts and so on. And it was a fantastic south to north thing. It was just like, it's really basic. People go, they knock on people's doors. They want to know who's sick, what they're sick from, who they've been in contact with. And then you go and you trace that person, and you go and find out who the other contacts are. And you tell them, don't do this, do that. You inform people, and you have this direct conversations with people. And Shobi talked about community health volunteers, and we don't have community health volunteers, but we have very strong communities in high income countries. It's just a matter of organizing people so that they are looking after each other, rather than it all falling on the GP and so on. So I think we could do a lot better in high income countries based on these very basic things that have been done highly successful. We know with these terrible epidemics like Ebola, like regular cholera outbreaks and so on.
So I know we're struggling for time, and there's a question from one of the audience about, to what degree has the crisis shown that necessity breeds ingenuity? And I suppose what I might do is just go around the panel and say if there's one thing you would want to see changed as we go onwards into COVID, because I'm not even thinking about post-COVID yet, because that's not very clear to me. So one thing you think that's come out from Ingenuity that we need to carry on doing? Shoba, maybe you could start us with one thing we must do and not stop doing.
I think, so I'm going to offer two, if that's okay, which is the first is around equity, because I think this has come up in all of our talks this afternoon, and the global Scalpel talks as well, is that once we achieve equity in terms of nutritional equity, alleviating poverty, all these end of the line things actually become a lot less important, and actually people's health actually becomes the focus. So I think that if we can do something around improving equity, that would be the greatest impact. In terms of Ingenuity, I think these technologies that we're using now and we're becoming really familiar with have been around for over a decade, actually. You know, YouTube Live was launched in 2011, and I think we're only just getting to grips with it. So actually embracing technology at this time, creating those collaborations across the world, has been something that I've seen has actually improved research, has really scaled things up on a bigger level, and actually contributed to the rapidity of getting these things out there. So I would say a focus on equity and technology.
I'm going to be in terrible trouble. You've had two in any case. Hilary, what one thing you want us to not forget and keep doing?
Thank you. So one of the joys, if you're allowed to have joys in a pandemic, to me, has been the level of breakdown of silos within the health system, the ability of people all across the health system to learn more about what each other do, what the needs are, what their risks are, how can we task share. These are, again, lessons that have been well established in lots of low-income contexts. It's been a delight in my hospital to learn more and to work better in teams as a result, and I really hope that we can hold on to that.
Thank you. Anant, you got 30 seconds.
Hand washing and wearing face masks.
Excellent. And finally, Anita, you get the final say on this.
Never waste a good crisis. I think that was something that Churchill, never waste a good crisis for change, and that to remember that nobody is safe until everybody is safe. And that so the globalization, actually we can use that for good. It's been difficult in terms of transmission, but actually the point is to use it for good, and that the entirety of the globe can benefit rather than just some countries or some individuals.
Thank you so much, all of you. So just if I can just summarize that, you want us to be fair, to embrace change and technology where it's good, to break down the silos and work together better, to remember the basics of hand washing and face masks. And unless we look after everybody else in the world, we can't look after ourselves unless we look after everybody else. Thank you all so much. I want to hand you back to Tony Jeffries.
Well, thank you, Ashok. Thank you, panel, and thanks to all our speakers. We're going to wrap up now. If anyone's listening would like a certificate of attendance, please complete the feedback survey. We are asking for your names and emails on the survey to ensure accuracy on the certificate. Please note that your responses will be completely anonymous. But do tell us what we did well, what we could have done better, and whether there's anything that you've learnt this afternoon will affect your practice, whether it affect your values or attitude, or whether you'd like us to do something like this again. And just to finish, Professor Kokila Laku will say a few words. Over to you, Kokila.
I have to bring this camera down because I'm not Tony's height. So thank you, everyone. As you can see, we've been working from our working space, surgical working space. I'd like to thank the audience first for joining us. Thank all the speakers for all the brilliant talks. Thank all the coordinators. And last but not least, I'd like to mention in name of the busy bees that were in the back room. I hope we can get their pictures on the screen, which is Ashik, Sai, especially Mehir, who coordinated all the technology, Tony that you met on screen, and Helen, who really coordinated the early parts of putting this together. I'd like to apologize for the Oxford University and hospital fire alarm that went off at 1500 hours, but brief. Also, on behalf of Chris, my colleague who leads the orthopedic team in our global work, he's sent his thank yous to everybody. And we look forward to you joining us next year when we hope we can have our meeting face-to-face, depending on COVID. Thank you very much, everybody, and goodbye.
Should we tune out?